Thank you for joining this special COVID-19 edition of CMEOCast entitled Coronavirus Disease 2019 and Inflammatory Bowel Disease. Dr. David Rubin has been kind enough to share his thoughts and insights with us today. Dr. Rubin is the Joseph B. Kersner Professor of Medicine and Section Chief of Gastroenterology, Hepatology, and Nutrition at the University of Chicago, and is co-director of their Digestive Disease Center. To address questions about COVID-19 and IBD, Dr. Rubin is joined by Dr. Miguel Reguero, Professor and Chair of the Department of Gastroenterology, Hepatology, and Nutrition, and the Pierce C. and Renee A. Bora Family Endowed Chair in Gastroenterology and Hepatology at the Cleveland Clinic, and Dr. Sushila Dalal, Assistant Professor of Medicine in the section of Gastroenterology, Hepatology, and Nutrition at the University of Chicago. Our learning objective for today's CMEOcast is to apply expert recommendations for the management of IBD during the COVID-19 pandemic. Welcome, Dr. Rubin.
Hello, everyone, and welcome. I'm Dr. David Rubin from the University of Chicago. Thank you for joining us. I wanted to talk a bit about COVID-19, the pandemic, and how it's affecting some of our patients. So first of all, remember that there are hundreds of different coronaviruses, and most of them circulate among animals, and some of them jump from animals to humans. There have been a couple epidemics previously described, like the original severe acute respiratory syndrome, or SARS, of 2002, and subsequently the Middle Eastern respiratory syndrome of 2012. These were both caused by coronaviruses as well. In December, as we've all heard many times now, a novel coronavirus, which has been subsequently named SARS-CoV-2, was discovered in China and subsequently has become the pandemic. It causes a disease that has been named COVID-19, which stands for coronavirus disease. 19 means 2019. As we understand it now, the incubation time is a median of 5 days with a range of between 2 and 11.5 days. And the clinical presentation is most commonly respiratory with infectious phase and then an inflammatory phase. The infectious phase is often characterized by fever and cough and congestion, but also obviously has characteristic chest abnormalities, bilateral pneumonia, and lab abnormalities, lymphopenia. There are also up to, depending on whose cohort you look at, 50% of patients who may have GI symptoms that include anorexia, diarrhea, vomiting, or abdominal pain. And also, depending on whose cohort you look at, these may precede or lag behind respiratory symptoms. One thing to keep in mind is just a pearl about this is that most people who develop the GI symptoms associated with this will also have the more systemic and respiratory symptoms as well. So as far as we know, it's not a common event at all to just have GI symptoms as the only manifestation of this particular virus. But we have learned that the virus has a point of entry through receptors that are expressed not only in the respiratory tract, but also in the GI tract. So we're going to look at a video which the CME Outfitter crew put together. And so you can remember, there's actually 29 different proteins that are involved in what we call coronavirus. The spike proteins on the surface is what people have targeted as potentially the way to develop vaccinations. And the N protein in the middle there is the nucleocapsid protein. And of course, you see the RNA, which is the main machinery of how this virus replicates. The AGA has developed a clinical practice update with a number of folks, myself included. And right now in the IBD space, we've been recommending that patients with IBD should continue their IBD therapies, and it's been emphasized the importance of staying in remission. This also includes continuing infusions at infusion centers that have safety protocols in place, including screening the patients as they arrive, space between chairs, etc. So far, as we understand it, having IBD itself, whether it's Crohn's or colitis, does not appear to increase the risk of contracting SARS-CoV-2 or the subsequent development of COVID-19. There's an international registry called COVID IBD, or actually Secure IBD, and it's at covidibd.org, which is publicly available if you want to see. There are now 877 cases of IBD patients who had confirmed COVID with their outcomes reported that are all available for you to see, and about a 3% mortality, or 30 patients who have been reported to die associated with COVID who also had IBD. So far, there's not been a spike of any specific therapies of interest except steroids, which are associated with worse outcomes in this infection, as they are with so many other things. In addition, there have been some instructions that have come out, admittedly with very limited data, but when patients develop COVID-19, especially when they're in that infectious phase, the first phase of the condition, to hold immune modulating therapies, including biologics, at least until the condition passes. There's great interest in whether our anti-cytokine therapies may actually be treatments for COVID-19 and reduce the systemic inflammatory phase of the disease. And there are actual trials going on in non-IBD populations to look at this, but that is not yet known well enough to say that our patients with IBD should stay on their therapies when they're first infected. So there's a lot we don't know. And of course, the half-lives of these therapies hang around longer anyway. So stay tuned. And if you do have a case of a patient with IBD who develops confirmed COVID-19 and you know the outcome, I really do encourage you to put it in this registry so that we can all learn from each other. So the clinical practice update that the AGA helped us put together describes how to approach patients with active IBD, as well as how to incorporate the management, or at least considerations, for the patient who has COVID-19. So if the patient has symptoms or findings suggestive of COVID-19 and they test positive for COVID-2, the SARS-CoV-2, the recommendation is, if they're on prednisone, try to get them down or off. And if you need to, switch to budesonide MMX. If they're already on 5-ASA or budesonide or other rectal topical therapies or nutritional treatments, you can continue those. The recommendations are currently to hold immunomodulator therapies, including our small molecule JAK inhibitor, and to delay additional dosing of biologics until the patient recovers from COVID-19. And at least in theory, and what we're interested in learning more about, is when patients develop the IgG phase of antibodies, presuming that those may represent resolution of the infection and hopefully at least some degree of immunity. Obviously, in patients who are severely ill and in ICUs, the management of the COVID-19 takes precedence over anything with the IBD, and they may even be enrolled in clinical trials now for some of those treatments. So this is our general recommendation. If the patient had tested negative and you were still strongly considering whether this was COVID-19 and other evaluations for workup were negative, you still should treat them as though they may have COVID-19. Remember that the nasopharyngeal swabs have a sensitivity of only 70%, which means there can be false negatives in some of those situations. And then, of course, evaluate your patient to find out why she may have been having active IBD and what else might be going on. So hopefully that gives you some guidance. There's a nice algorithm that describes the rest of this in that GastroPub, which is also available at the AGA website. And we're going to go back to a few things. I'll start with the questions we have about COVID-19. I think they're very thoughtful questions and they're practical ones. The first one is that someone wanted to be reassured that we think patients with IBD are not specifically at increased risk for getting SARS-CoV-2. So Miguel, let me ask you how confident you are in that, and maybe you can reflect on the IO-IBD consensus that you participated in as well.
Yeah, so I think, one of the, I realized Sushila did virtual visits or telemedicine all day and probably didn't get through a visit without COVID-19 coming up with a question. And I think it is reassuring. So what we've seen from the secure registry, from our discussions and analysis through the IO-IBD, is that the percentages of patients presenting with COVID who have IBD are fairly low, and certainly much lower. I was even looking at some data earlier today, much lower than hypertension, diabetes, obesity, pulmonary diseases. So I think it's early days, and to say that this has really been something we've been analyzing in 2020, and to say we know everything isn't true. But at the same time, I am reassured by the early data. I think if there was an uptick, we should have seen it by now. Also nice to see that it's not overrepresented in our patients who are on immunotherapies of any type, which is also reassuring.
Yeah, I would add to this, there's a distinction between saying that someone with Crohn's or UC in and of themselves are at increased risk versus incorporating the possibility that our patients on immunotherapies might be at increased risk. It's an important distinction, but it's something we should keep in mind. In addition, there are data from the original SARS epidemic in 2002 through 2003 that suggested that those who were on immune therapies, not just with IBD, but other conditions, did not have an increased risk. There's the case series from NYU of immune-mediated diseases that's in press right now in the New England Journal of Medicine, where they did not see anything specific other than age and some of the other comorbidities we've already seen, and possibly steroids as well. So you're right in asking this question, but in the meantime, we don't think that our patients in and of themselves having IBD puts them at increased risk for this particular infection. On the other hand, we certainly know that our patients on these therapies may have some risks. So Miguel or Sushila, the next question from one of our participants tonight is, what data do we actually have that TNF inhibitors may put people at increased risk, such that we would even suggest we should hold them? And then another person, or maybe the same one, said, given the half-lives of these drugs, what are we actually doing by telling them not to take them for a couple of weeks? Who wants to tackle that?
Sushila, do you want to answer? I'm happy to.
You can go ahead. Sure.
So I think, these are excellent questions. To start with the anti-TNF question first, and then I would probably broaden it to medicines. We have not, based on the data such to date, have seen increased rates of infection with COVID-19 in patients on anti-TNFs, or for that matter, any of the biologics. What we have seen or are concerned about is that higher levels or higher doses of steroids may actually be associated with worse outcomes in COVID-19. So if I were to separate it into, do the medicines predispose to COVID-19? We haven't seen that for our medicines. When the patient is infected with COVID-19, we try to avoid or limit the medicines that may be associated with our worse outcomes in viruses. So over 20 milligrams of prednisone or equivalent, the tofacitinib, the thiopurines. As far as holding the medicines, you're right, or whoever was asking the question's correct. There is a washout period with thiopurines and others. Nonetheless, I think it behooves us in the sick patient in the ICU, for those that have seen those patients, we're going to practically stop their immunotherapy. If it's an IV or a subcutaneous dose, and they're due for that, missing that or delaying that dose for a couple weeks is fine. So I think it really comes down to the daily therapies of thiopurines, tofacitinib, steroids, where we really would want to withhold those. Understand there's a washout of thiopurine, short half-life with tofacitinib, but we'd still want to hold those medicines.
Yeah. I would encourage folks to go to the covidibd.org website and look at some of the data. Admittedly, they haven't done a multivariate regression to control for different variables, but you'll see that there hasn't been a clear spike. And maybe the numbers of patients, thankfully, who've been in the ICU or who have died are so small that we can't see that at this time. But the person who asked a question about cytokine storm being prevented by our anti-cytokine therapies is certainly a very reasonable thing to think about. We do know that there are trials going on now with anti-IL-6, anti-TNF, and with JAK inhibition in COVID. So there may be benefits here, but in the absence of that, it seems practical that at least in the infectious phase, not dosing someone with the drug is practical. And this is just pragmatic until we know more. Certainly understand that. Okay, another question. Sushila, should we be checking for SARS-CoV-2 in everyone who presents with a relapse of their IBD?
I think that at this point in the pandemic, it's reasonable to do so, given that the symptoms of a relapse would often overlap with possible symptoms of COVID-19.
So certainly if they had otherwise been well and you don't have an otherwise identified reason, we certainly also know some patients who have just stopped all their therapies or didn't go to their infusions where it might be more obvious, but I think that's practical. Miguel, is the Cleveland Clinic offering serologic antibody testing?
So it is that, yeah, that's the whole testing is a loaded question that we debate, and probably an hour doesn't go by in our days where we talk about this. So to be clear on the testing, there's the nasal swab, or what will be saliva RNA testing, which is to show is there active infection. Then to David's point, the serologic testing, IgM, IgGs. And then the debate or the dilemma is that there are some questions about the sensitivity and specificity of the serologic testing. To answer your question right now, while it's offered at Cleveland Clinic, we're not routinely doing this today. Everything changes each week. There's an interest from the healthcare standpoint and provider standpoint of having a good serologic test to let us know if we're somehow protected. The other part of this, as you might get to, is even if you have serologic IgG, we think that's protective, but we don't know, and there's some question about different strains, whether you could get a reinfection. So a lot of unanswered questions. We're not routinely testing serologic testing today.
The primate animal research suggests that IgG is protective, and we obviously want to know that in humans, but that seems reassuring. The other thing to keep in mind is there's actually no serologic test that's FDA approved. There are several that are being reviewed. So there's many out there, but they're not all the same, unfortunately, so apologies. I'll just ask two more questions, specifically about PPE for colonoscopy. So in a patient who you do not suspect has COVID-19, are you using the same PPE at the Cleveland Clinic? Or Sushila, you can talk about the University of Chicago. And are you pre-testing everyone, whether you suspect it or not, before they have scopes?
So probably these alone have occupied 30 hours of our day the last 3 days. So PPE, to start with that, our guidance at Cleveland Clinic is in the absence of testing in an asymptomatic patient, we are using N95s, which is the key component of the PPE, in all of our upper endoscopies and our colonoscopies. That is what we're doing today, and that's still the guidance. We do use single-use all-day N95s, and I think most sites are doing that, and we can get into the details if you would like. As far as testing before endoscopy, the answer is no if the endoscopies are being done in a endoscopy-contained unit, so an ambulatory endoscopy center or an only endoscopy center in the hospital, we are not testing. However, if the endoscopies are commingled with patients who are undergoing surgeries, ambulatory surgery center, those patients are being tested, not because we're necessarily worried about a test positive patient who's asymptomatic having a complication with a scope, but it more has to do with the commingling of patients in these units. And there's a lot more behind it, but I'm giving you the Cleveland Clinic answer, and I'm curious to hear what you're doing in Chicago.
Sushila, do you want to tackle it, or do you want me to take it?
You can take it.
Yeah, so similar to you in PPE use, we do have extended use N95s. The policy is if you take it off, though, you're done with that one for the day. We also have ultraviolet recirculation cleaning of the N95s. Although we haven't needed to do that, it's being done to preserve what we have. We are testing everyone at the current time. They have to come down, though, the day before. We do have point of care tests, but they're in limited supply and used predominantly in the ED. So we are testing everyone at the current time with the idea that, although it doesn't change PPE, because we're using full PPE right now, if we did find someone was positive, we would do their scope in a negative pressure bronch room or in the OR where there's negative pressure rooms rather than in one of our endoscopy rooms. This is still evolving, and I would refer folks to the multi-society guidelines on endoscopy that have come out to read more about this. And the IBD website has the endoscopy task force commenting on some of these things.
And the only other thing I'll add to what David said is I think it also has to do, and you probably can't turn on the news without seeing this, the accessibility of testing too. So as we ramp up our endoscopy volumes and get up to high volumes, we will have patients who come in not tested, even into centers that we want to test. And I think we just have to use good practical guidance. If they're asymptomatic, they don't have a fever, probably not needing to cancel those patients, but that's a personal opinion.
All right. And the last question about COVID for now, although more floating in, is do we think that COVID-19, when it causes GI symptoms, raises calprotectin? I think that's an interesting question. Our GI pathologist, John Hart, who's just a wonderful expert, is part of an international group of GI pathologists. And they've described that patients who've had biopsies of their intestinal tract during this pandemic have not had histological abnormalities, sort of akin to cholera, which also doesn't. So you might predict, given that calpro comes from activated macrophages and neutrophils, that a pure COVID-19 associated GI symptom of diarrhea would not elevate the calpro. So if you do have an elevated calpro, look for the IBD relapse or a different infection. At least that's the thought. And I think there needs to be more done here.
Yeah, and the only thing I'd add, so I agree with David, the only thing I'd add to that is people probably know that the ACE receptor is what likely the COVID attaches to, and this is found through the GI tract, the enterocytes. The only exception to that, and we did have a couple of these patients, not IBD, because of the microthromboembolic potential for COVID patients, we are seeing some ischemic colitis. Now that's different than what you're referring to with just pure diarrhea and COVID, but keep that in mind. If you have a new onset bloody diarrhea and somebody's sick, it could be an ischemic event.
Good luck, and please everyone stay safe as we get through this unprecedented time in all of our lives.